I'm Adam Woolley. I am a assistant clinical professor at Northeastern School of Pharmacy, Department of Pharmacy Practice, and the Bouvet College of Health Sciences. And my practice site is at the West Roxbury VA for internal medicine.
Okay, can you tell us briefly a little bit about your study?
In terms of the article that I'm here speaking about today, I did in collaboration with one of our pharmacy residents, Dr. Alyssa Halsley. And what we did was really kind of review the literature to look at the question of drug underdosing, underprescribing in patients, and looking at possible effects in polypharmacy.
Could you tell us how medication underdosing and underprescribing affect our audience, managed care and hospital decision makers?
Well, I think in regards to your audience, medication underdosing and underprescribing are very important. Your formulary managers are looking at prescribing restrictions, they're looking at therapeutic interchanges, as well as protocols that really guide use towards cost-favorable drugs. And I think that we can agree that we're all vested in medication safety as well as dosing, and I think it's important for them to consider the potential implications of underdosing and underprescribing. And in my experience, I think they're in a good position as well to evaluate drug utilization at their specific institutions, as well as in positions where they can factor in and assist with some of the decisions made in pharmacy staffing and potential ways to help minimize underprescribing and underdosing.
In your study, you talked about polypharmacy as a potential consequence of medication underdosing. Can you talk a little bit about that?
In regards to polypharmacy, I just want to be clear that it's a general term that's kind of thrown around, typically referring to patients that are on more than 5 medications at once, but many times polypharmacy is needed for these patients to have adequate therapy to treat their disease states. The negative aspect of polypharmacy really reflects on when there's therapeutic duplications, when there's drug interactions, when patients are taking more medications than are needed. And I think to really consider polypharmacy and the effect that underdosing and underprescribing have, just going back on patients that may not understand their medication regimen, may not be taking their medications properly, maybe they're on some certain pain meds that they're scared to use, they may not know enough about, and maybe they're going and buying other over-the-counter medications such as ibuprofen or aspirin or Tylenol, leading to more polypharmacy, taking more meds for their untreated condition, whereas if they had increased their dose or taken their medication as prescribed, they would not need additional medications, which of course, as we know, come with more potential drug interactions and adverse drug events.
Talk about some of the barriers to medication optimization.
In terms of barriers to medication optimization, I think there's really 2 major things here. One of them is just communication amongst healthcare providers, whether it's with physicians, physician assistants, nurses, pharmacists, as well as time to spend with patients and really get to know each individual patient well. I think from a pharmacist perspective, when we're in the hospital processing orders, we're often responsible for a large number of patients, and we may not know each and every patient very well, and what specific difficulties that patient may be having taking their medications at home, or what understanding they have of their medications, as well as if they have any side effects. And that's something that maybe a physician may know about, or the nurse, and really trying to communicate. It's hard for me, processing an order, to really know what the clinical indication is for the med, and just seeing if the dose is within a normal dose that a patient would take. So whether that's lisinopril 5 milligrams or 40 milligrams, those are all reasonable doses, but what's the optimal dose for that specific patient? Are we optimizing doses in heart failure, in patients that need that in diabetes? Are we monitoring and keeping the doses where they need to be? So also just ensuring that there's follow-up upon discharge from the hospital. And one of the examples we used in our paper that we would see is when a patient comes in with acute renal failure, they receive an antibiotic for an infection, and it's appropriately dosed based on their renal function at that point in time, but making sure that the institution has mechanisms in place to follow up a couple days later if that renal function resolves, to ensure that the patient is still receiving an adequate dose. We may need to increase the antibiotic, and if that does not happen, there's the risk that the patient will have a prolonged hospital stay and possibly require more medications to treat the infection. That's just one example of several. And I think just in our culture, we tend to think of, what's the highest dose a patient can have, and we're really scared of overdosing a patient, and we feel a little bit more comfortable giving them a lower dose. It's probably not going to hurt, but we really need to reflect on that and think, are they getting the intended efficacy of this drug, and are we preventing further worse outcomes? In talking about the role of the pharmacist, in our paper we talk about the fact that drug-related hospital admissions are really attributable to a large percentage, at least, attributable to subtherapeutic dosing, non-compliance, and untreated indications. And these are things we know pharmacists can really assist with. We know that pharmacists can help to educate providers about appropriate doses, as well as educating patients. I think patient education is one of the large take-home points here, because we can try our hardest to get them on the right medication, but it's really making sure during those transitions of care that they know what they're supposed to be on and how they're supposed to be able to take it, and really getting the patients to buy in. So looking at what pharmacists can do, and in terms of evaluating the care plan, seeing what specific goals of therapy there are to help titrate medications, as well as preventing ADRs. But some of the interventions that we talked about in our paper, even specific to the VA, we actually utilized the pill clinic, or the pharmacological intervention in late life, where our pharmacists will actually call patients and make sure that they understand their regimen, and that has really been found to help decrease readmissions, decrease prescription costs. So that's something that's been beneficial. And using things such as the START tool to think about whether a medication has a clinical indication for a patient, as well as just the pharmacist's role in heart failure clinics, as well as antimicrobial stewardship to help ensure appropriate doses, are all examples of the pharmacist's role. And I think it's a role that's going to be really expanding, and things that we can do to help our patients. In terms of a take-home message for our paper, really just to have all healthcare providers thinking about the possible effects of underdosing and underprescribing for patients, and really advocating for better communication amongst healthcare providers, as well as patient education. And I think future implications of this are really to help look at potential research avenues to see what, all these interventions that we do put in place, what are their effects on patient outcomes, and how can we share our best practices, and really encourage others to publish reports of their experiences and interprofessional approaches to managing this problem. And I think the new ICD-10 codes, which will identify drug underdosing, will help to facilitate some of that research.